So I'm here today with Dr. Janet Tsang. Thank you for coming in today.
Oh, you're welcome. Thanks for asking.
I've known Janet for many years now, and I absolutely would not be here as happy today as I would be without Janet coming into my life years ago. So I thought we'd invite Janet in today to talk to everybody, well, females really. Well, this is about females helping females today.
Yes, middle-aged women.
Middle-aged women.
Yeah.
You won't believe it, but this woman here is in her mid-50s. Amazing.
Pass on the wisdom.
That's right, I've got her here to pass on the wisdom. So she has helped me tremendously, and I really wanted her today to try and help all of our clients out there today who might be going through some of the things that I went through a few years ago. Just very briefly, my journey began probably when I turned 40. I was fine. I would say I was in my early 40s, maybe 43, 44, when I started getting really bad heart palpitations. And that's something I've never struggled with. I've never suffered with anxiety or anything like that. And so I actually thought I was having a heart attack. Went to the hospital one day. That's how bad they were. Had no idea what they were. And my journey took me to Janet, and from there I've had a hysterectomy, I've had all sorts of things happen, and I just thought we'd talk about that a little bit because estrogen has been an absolute saviour for me, but I was always very comfortable with HRT. So I wanted today to have Janet in here to talk a little bit about HRT, about it for women in perimenopause, about it for women in menopause, as well as, there is obviously non-HRT things that you can try as well. I did have a go at things like Happy Mammoth and some of those other more natural alternatives, but I needed something a lot stronger. And we'll also maybe talk a little bit about Lexapro, because there was a period of time where I wouldn't have survived without a small dose of Lexapro while I was going through all of the working out hormones. So I'm going to stop talking because I talk far too much, and Janet also loves to talk. So I'm going to hand over to Janet. We're just going to maybe talk together today.
Yes, I think interactive would be good.
Yeah, I agree.
Yeah.
So Janet, women, it's probably mid-40s, would you say, is when you start seeing women?
Well, we'll get some definitions right first, because I think this is really confusing for women. So what is menopause?
For me, menopause is when I no longer get a period.
Well, technically, yes, menopause is really the end of your reproductive life. So, it is the final menstrual period, but medically, we define post-menopause is like a retrospective diagnosis, because post-menopause means that you have to not have had a period for 12 months. Yeah. Okay. So, the average age of menopause, what do you think is the average age of menopause?
53.
Generally, it's between 45 to 55. Yeah. So we describe, this is the average age of menopause. There are different subtle racial differences. So if, we go to a lot of international menopause conferences and stuff. So Asians may go through menopause around about 47, 48 on average. So every country is slightly different, but generally between 45 to 55.
Okay. Yeah. I won't know, I actually had a hysterectomy done 2 years ago, and I did it because I was getting really heavy periods, and they ended up saying after I had the hysterectomy, it was really easy. I was in and out of hospital 24 hours, I had no problem.
I had a great gynecologist.
I had a great guy, did. And he actually found that I had endometriosis on the outside of my uterus, which wasn't picked up, which was probably giving me a lot of that heavy bleeding and
pain.
Yeah. So it was actually lucky for me. But I also did it because I didn't want to go on the pill, because my gynecologist had said to me, probably as you start to head towards 50, get off the pill. And so he said, if you have a hysterectomy, you can just go on estrogen. So that was what began me on the journey of the hysterectomy. And so it is a lot easier for me because I don't need to take progesterone. So my sister-in-law has just gone on to estrogen gel, but she's my age as well. But she needs to take the progesterone.
Yes, if you have an intact uterus, you have to take progesterone. There was, back about 50 years ago, when women were put on estrogen as you go through menopause. They didn't know that you had to use progesterone for endometrial protection. So after a few years, they realized that there were women coming in with endometrial hyperplasia and endometrial cancer. So now nobody is going to use estrogen without progesterone if you have an intact uterus.
Yes. And so, tell me, Jenna, on that, like years ago, I know my mum never went on HRT because she was, terrified of breast cancers, and the media at the time, which was 20 or 30 years ago, had obviously scared her out of going on HRT. And I actually don't know how I'd survive without it. So what's changed, do you think, from 20 years ago to now, where it seems to be a lot more common?
So when I graduated in the 1990s, a long time ago, we were taught to prescribe estrogen to women who have gone through menopause. It's for bone protection, because we already knew at that time that women in the menopausal years will have osteoporosis, until the Women's Health Initiative studies came out. So around in the early 2000s, there was a study which is called the WHI, the Women's Health Initiative, and they released premature results, which was really scary. Numbers which were like increasing the risk of breast cancer, increasing the risk of blood clots. So all the patients decided that I don't want to use this anymore, and the doctors were too scared to prescribe. So for probably a whole decade or more, women were missing out on estrogen. Doctors were too scared to prescribe menopausal hormone therapy. And they weren't being taught properly in medical school. So you probably have a generation of doctors which wasn't taught how to prescribe menopausal hormone therapy.
And that's like that. I honestly feel like there's not negligence, but it's disappointing for all those years.
Yes.
Because what's sort of surfaced now? Has it surfaced that it's not what they thought it was?
Well, now they have to review all the numbers, and then they have to look at all the the bias results, and they have to reorganize all the results all over again. And then now they realize that, hey, look, it's actually not that bad. We shouldn't have stopped hormone therapy. We should have been a bit more selective, though. Now that we know what we know.
Yeah. So there's benefits, though, isn't there? There's benefits to the brain, benefits to the heart.
Yes,
there's actual benefits of estrogen.
So the more you study, estrogen receptors. We have estrogen receptors all over our body. So we've got estrogen receptors in our brain. So in our temporal lobe, in our frontal lobe. There's a reason why we complain of brain fog. There are estrogen receptors in our bones, in our skin, in our liver. It is everywhere. So when we don't have any estrogen, we would feel it. Some women feel it more than others.
Yeah, that's right.
Yeah.
And so by taking estrogen, it does keep our skin healthier, hair healthier.
Well, true, but that's not the reason why we use
the brain as well.
Yes,
and the heart.
So at the moment, to prescribe menopausal hormones properly, you have to have menopausal symptoms. So it is for the relief of significant menopausal symptoms. That's the reason why we would use menopausal hormone therapy.
I guess you wouldn't need it if you weren't having symptoms anyway, because that would probably assume that the estrogen levels are at a fairly good level still. Or do some people just not suffer at all with?
Well, you see, some women will complain significant symptoms, and then you'll have some women who just breeze through it without any symptoms. But generally, on average, according to most studies, I think 70% of women will suffer from some kind of menopausal symptoms.
That's huge. So I'm focusing on estrogen right now. We will get onto other things. But so with estrogen, taking estrogen now, you shouldn't feel like it's going to do harm. Like it's not going to, what's the general consensus about taking estrogen? Is it good for you? Take away the fact that it takes away symptoms, because that's amazing, obviously. But looking purely at health, is it good for us, or is it still something to be cautious of?
There is always going to be, there's no drugs without any side effects. If there was, I'll be, sipping cocktails on the Caribbean. So you always have to take the good and the bad together. But I think now the thinking about menopausal hormone therapy is quite different from, say, 20 years ago. So we have to relieve women of their symptoms.
Yep, so that's obviously
the priority.
Yes.
But then we also have to think about the future health. But this is this is probably another new wave of thinking. Is even if you don't have a lot of symptoms, we are still thinking about the future health of the woman.
Yes,
Yeah, right.
Because is it true that once you reach menopause, women often have more heart attacks after menopause?
Well, yes, we'll get to that in a moment. Talking about breast cancer, the breast cancer risk, just to put it in perspective, if you go to the British Menopause Society, there is a website for the British Menopause Society. They have a lot of resources and information for doctors and consumers alike. So there is they follow a group of British women. So just by being British, between the age of 50 to 59, they follow them up. And just by being British and doing nothing else wrong, your chances of having breast cancer over 5 years for every 1,000 British women is 23. Okay. Now, if you exercise at least 30 minutes a day and you do enough exercise each week, that number reduces by 7. So it's like it reduces by about a third. If you have 1 to 2 glasses of alcohol, that number increases by about 3 to 4. If you're on estrogen only therapy because you had a hysterectomy, the number reduces by about 3 or 4. If you are on combined menopausal hormone therapy with progesterone, a combination, the number increases by about 3 or 4.
Okay.
So we know that the breast cancer risk is not just being on HRT. So it's not just estrogen, it's your lifestyle.
Yes.
Because remember too, between the early 2000s until quite recently, there is a lot of women who weren't being prescribed menopausal hormone therapy. Now, back in the 1990s, when I graduated, I was told that your lifetime risk of breast cancer is 1 in 12. So you would assume that, because everyone came off estrogen, that the lifetime risk of women having breast cancer would reduce, right? But it didn't. It actually is now about 1 in 8, 1 in 7 or 8. So there are a lot of lifestyle reasons why we get breast cancer, not just estrogen.
Do you think that's like in Japan? I think breast cancer is very rare in Japan. Is that?
We will still need a bit more study to find out why they have less.
But possibly lifestyle, food.
Yes.
Lifestyle.
And being overweight basically doubles your risk.
Yes.
So, I'm talking about your weight, your cigarette smoking, your being sedentary,
So estrogen has got benefits. Yes, there are, but potentially if you're constantly having breast checks, if that is something you're concerned about, there's a place for
but
estrogen.
if it is something that you're concerned about, you can also, there is a website, which is made in Australia, it's the Peter Mac, it's like an iScreen. So if you Google, I can't remember the full address, but if you Google Peter Mac breast cancer iScreen, it is at least like a 30-minute long questionnaire. So you will type in all your data, your weight, your history, your family history. So it will, at the end of it, when you finish that questionnaire, it will actually give you your risk of having breast cancer.
Okay. And one last thing on estrogen. So if I was 60 and I came to you, I had menopause, 5 years ago, but I just felt a bit flat. I wasn't sleeping very well. I might not be having the sweats anymore, but I don't feel great. A bit depressed, a bit anxious. Would estrogen therapy be something that you'd look at?
There is no upper limit. Number one is that if you have already been prescribed it, there's no upper limit when you would have to stop it.
So I could keep taking
You
estrogen
can
now
keep
till
taking,
I'm 80?
yes, until you're 80 or until you are diagnosed with a hormone-dependent tumour.
Okay, that's great for me.
Yes.
So what about if I came to you at 60 and I'd not had anything,
Yes.
but my girlfriend, had been on it for 10 years, she still felt great, was sleeping well, and I said, Janet, I want to be like her.
Yes. So we also now know that if we put a woman on menopausal hormone therapy, which is like mainly estrogen and plus progesterone for endometrial protection, then we know that we can preserve the bone density. So there is actually a bone protection.
Okay. So
yes.
What about symptoms though? If I'm 60.
If you still have significant symptoms, yes, we can still prescribe, but all your benefits from a bone point of view, from a cardiovascular point of view, they probably aren't going to be
as great as if you were taking it from a younger age.
Yes, that's right.
Would it still potentially help my sleep, the quality of my hair?
we will probably have to maybe think of other medications, you know, if the estrogen alone is not going to help. I mean, we can try, you can try.
But, I know, so it is very individual, isn't it?
Yeah.
A female plan is very individual.
Yeah,
plan.
so I think every person needs to go to their, you know, needs to find a doctor to analyze all the symptoms individually, and then to discuss, you know, what are you going to gain out of this, but what do you have to lose?
Yeah,
you know?
that's right. I think the other thing I love about having somebody, so I've got Janet, you know, someone like Janet, is that when things start to go a little bit, like I'll be great for a year and then suddenly I'll start to have a little bit of sweat again, or I'll start to get a few palpitations again, I can call on Janet and we can look at some things that it might be that I just need one more smear of estrogen, or it might be something as simple. At the moment, Janet and I have just talked the last couple of months about a tiny little bit of testosterone. So that's a new thing that I've not tried before. I know it's getting quite big overseas.
Yes.
I think more on a celebrity effects of testosterone at the moment. But I have to say that I've used it for a little bit, just a very small smear, and the energy, I have to say I have a lot of energy and a lot of other benefits actually from the testosterone as well. And so tell me a little bit about this, because it's fairly new, in as much as I've not ever it's not something that we talk about a lot.
It's not that, I mean, you know, I've known about it for a while, but
you know me then.
Yeah. But let's put it in perspective. Because testosterone replacement therapy is only indicated for hyposexual desire disorder. So you have to have significant symptoms of low libido, it is affecting your life, before you're going to get real benefits out of it. So it's really good that you did, that you get benefits out of it. But there are side effects too.
Yes, that's what actually I'm interested in those, because I probably didn't go into too much detail about those with you.
And I probably prescribe, like, you know, testosterone cream to you know, a number of women, and you know, I would be lucky to have some who have really good results, and then some people will come back and say, oh, you know, didn't do much, it's a little bit overrated. I've really just a tiny bit for me, but I think I've got a lot of, if anybody knows me, they think I'm type A personality anyway, so a tiny bit of testosterone. I'm sure you checked all your thyroid already.
You did. So we did full checks. But a little bit of testosterone went a long way for me, and it was I my sleep. I did take Lexapro for a little while to stop just that feeling of anxiety. Even though I wasn't anxious, I never felt mentally anxious. It was like physiological.
And anxiety is a menopausal symptom as well. Yeah. But you know, I don't think there is actually enough data to say yes, menopausal hormone therapy can be used to treat depression. I don't think we can say that.
No, but it did for me. So like I went off the Lexapro once I felt really stable. But it did take me over a year to work out where my estrogen level was. You know, like from 1 pump to 4 pumps to the pill.
Yes.
And so it took me a little bit of trial and error.
And it's interesting, you know, the transdermal route didn't work quite as well for you, because there are also studies to say that for some women, they just don't absorb estrogen through the skin very well, and they have to take it orally.
So I'm taking it orally now, which everyone seems to be okay with because I'm not quite 50. Do you think what's your view of me taking it orally till I'm in my 70s?
Well, this is the thing. I think menopause hormone therapy, you know, before you start, you need to make sure that you go and see your doctor. You need to have your, you know, appropriate screens, you know, your routine checks, you know, everything, all your health all checked up, and make sure that we're not missing anything before you get started. And then it needs to be reviewed on a regular basis. Yes. We need to make sure that, okay, the dosage is right, we don't have to titrate it up, or we don't have to titrate it down, you know, and so on. And because you were still perimenopause, so you haven't gone through your final period at that time. So we had to talk about fertility as well, because, you know, if you're in your peri, you still have a risk of falling pregnant. You know, if we put women on menopausal hormone therapy, it is not a contraception. So whilst it may relieve some symptoms, it may not necessarily make your bleeding pattern any more regular, and you may still fall pregnant on it. So for some women, we actually have to put them onto some kind of like a low dose pill until they turn 50, you know, so on. So every woman's a little bit different.
Mirena, is that
Mirena is another one. Yeah, that's a good one. So Mirena makes life a lot easier, because, you know, you can put a Mirena in some women, and then all they need to do is just to focus on, their estrogen patches or the oral estrogen, because the Mirena.
Progesterone with Mirena?
If you have a Mirena, it means that you still have an intact uterus, but the Mirena will be giving you the endometrial protection.
Oh, that makes it easier, so you don't need to remember.
Yes.
Because the trouble with that progesterone is remembering to take it from.
Yes, that's right. And also because with the endometrial protection, the risk for endometrial cancer is lowest when you can perfectly match the dose of your progesterone to the estrogen that you're giving to the woman. So you can't give too much estrogen and not enough progesterone.
That's right. That's why I just don't have the.
Yeah. So now you also have preparations where they already have estrogen and progesterone 2-in-1 patches. Yeah. You already have estrogen and progesterone tablets 2-in-1. So that makes life a lot easier as well.
Tell me a little bit. Oh, actually, one more question about if you're 60 and you've already had menopause, you've got an intact uterus though.
Yeah.
Do you still need progesterone?
Yes, you do.
Oh, okay.
Yeah, you do.
Okay, even though you've had menopause and you no
yes,
longer.
That's right. You'll still need progesterone. But this is the other thing. It's like, what do you do with the oral estrogen in 10 years' time, in 15 years' time? Now, your body's going to change. So as you go through menopause, and your body may downregulate your estrogen receptors, so you may actually have less estrogen receptors in 10 years' time. I don't know. So you may need less estrogen. Maybe you can be converted back to topical.
I think I was on the topical. I think this is I've made this up, and so you'll probably correct me. But I felt like once I went to 2 mil, it overrode my normal ebbs and flows, so that now I honestly feel like I'm back in my 30s. As far as I'm constant, I sleep well. I feel like I don't get headaches, I don't get any ups and downs. I feel like the 2 mil just overrides my ebbs and flows. Whether that's true or not, I feel like 1 mil didn't quite do it for me.
Yes, and I think everyone's different. You may be able to go down to 1 milligram later on. As you age. And the idea is that we only want to prescribe the lowest effective dose to manage that woman. If 1 milligram works, why do we need 2 milligrams?
Yeah.
Obviously you're on 2 because the 1 milligrams didn't work.
Yes, it took me a while to work that out, and then I will obviously every year or 2 years try and drop.
And there are reasons between oral and topical, because we now know that, look at a few different scenarios, because there are women who are, say for example, if they are at high risk of having thrombosis or blood clot. So we know that using an oral estrogen, whether it is a bioidentical or a synthetic or a conjugated one, anything oral will still increase the risk of a clot. So then for women who are at risk of a blood clot because they've had one before or they have a family history, then you're still better off using a transdermal delivery system.
Patch is better than the gel, do you think?
Patches is great in the sense that except for the first patch in the first 72 hours, once you change at the right time, it gives you a really good steady level. Yeah, it doesn't go up and down. When you actually take an oral hormone, a tablet, there is a little bit of a fluctuation of hormone levels in your system.
I need patches.
the other problem with patches is the supply.
Yes, yeah. It's hard to get, isn't it?
Yes. Sometimes you've got ones which
now, is that because the government just put them on what's the PBS? Is it just gone on the PBS now, so they're a lot cheaper?
A lot of the menopause hormone therapy are now available on the PBS, so it will be cheaper for women.
Yes, yeah, okay.
Not that they were overly expensive before, but
no, but that's now I lost my train of thought. I was going to ask you something really.
Yes, but the other thing too is that there are some women who have migraines. They have migraines. Migraine is another risk factor, because women who have a lot of migraines, especially the ones with aura, they have visual disturbances, and that actually puts them at an increased risk of having cardiovascular disease and strokes. So generally, women who have migraines or who have a clot or who have significant cardiovascular risk shouldn't use an oral route. They're probably better on topical.
Or patches.
Or patches. Yeah, patches, which is patches or gels.
Is the oral HRT the same risk as going on the pill when you're younger?
No, you're talking about different estrogen. So the pill contains, say, for example, the synthetic estrogen, estradiol. You know, they're different from, you know, equine estrogen, which is like from, you know, the estrogen and the, you know. So again, the risk of some of the pill estrogen is higher risk than the other conjugated estrogen. The lowest risk will be the body identical one, which is estradiol.
Okay. So if you've been on the pill throughout your life and you've coped okay.
Yeah. But now that, you know, for the perimenopausal women, there are newer pills which are, you know, where the estrogen is actually estradiol anyway.
Okay. So it's a safer.
The safer.
Okay.
Yeah. Safer pills.
Yes. Yeah.
More body, you know, neutral.
Yeah.
Yeah. Or one of the new ones is a new kind of body identical estrogen from the fetal liver.
Yes. Okay.
Yeah.
That sounds interesting. Can I also ask, so one more thing that seems to affect everybody I speak to at my age is sleep. So if we didn't want to do hormones, is there something that you can take to help you sleep that isn't, you know, like overly addictive, that just puts you to sleep, lets you have a great 8 hours, wake up fresh?
That depends on what's causing the insomnia.
Let's say it's hormones.
If it is purely your hot flushes and, you know, and you're having temperature issues.
Well, it's not even that. I feel like, yes, I get that, but I feel like some of the people, women I speak to, it's like their body clock. So at 3 o'clock, they're awake and they're just wide awake. And then 2 hours later, 5:30, they can doze back off. But
there are some women who have they can't sleep because their hot flushes keeps them awake.
Yeah.
And so there is actually a new tablet. Well, it's been out for a couple of years, and it is not a hormone, and it actually works on blocking you know, some of the you know, peptides in your brain, which is in the temperature sensors. It's kind of like, I call it temperature sensors because, you know, if I was to explain it, I'd probably have a brain fog and I can't.
you shouldn't.
But put it this way: in the brain, we have you know, we secrete different kinds of peptides to tell our body when to secrete, when to pop an egg out. You know, so they're the same temperature regulation control that sets our body clock. So there are there's a medication, and well, there's one anyway, and I can't mention the name because, you know, we're not allowed to mention any extra drugs.
But they'll be done.
Yes, but there's probably more coming out.
Yes,
so they actually block those temperature sensor receptors.
What if it's not the temperature though? Like, I don't feel like when I wake, before I was sorting myself out, it was from the temperature. I felt like it was like my heart maybe, or I was just awake.
Well, there are, you know, we'll probably have to take a much longer thorough history to see whether we can get to the bottom of it.
Yeah.
But you know, maybe some women need an antidepressant or other sedatives, or, you know.
I had a friend of mine who was given NDEP.
Yeah,
take it right.
That's like a low dose antidepressant.
Oh,
yes.
is it? Okay. That does her very well. So she takes half an NDEP.
Yes.
I know it's
very, very low dose.
I probably shouldn't have said that, should I? I'm not a doctor though, so I get away with this. And so I know everyone's different, and I feel like I've worked with Mikhail. I've worked with Mick for 25 years. She's over here today. And like my sister-in-law, and I feel like coming into your 40s, women really get back together and start to talk about some of these issues that we all, for years, haven't really talked about a lot. And when you find somebody like I found you, it's gold. I just feel like no matter what I go through, I can turn to you and I can say, Janet, what do I do now? Or I don't feel good, or my heart's racing again, what do I do? And that's for me, that's the best gift that you've given me. And I really wanted to let our clients know that if you can find someone like Janet, and Janet, I mean, anyone in Brisbane can go and see Janet, but Janet's a big believer in finding someone, you know, that you could do a Zoom with Janet, but we were saying that face-to-face is often better. And what's the deal with Zoom? You were just telling me before.
Well, I think if you can examine a person properly, this is great, because, you know, commonly you will want to see that person. You might want to update your cervical screening. You might need to examine someone's breast. You might, sometimes you need to see a person face to face in order to have a feel whether they're actually really depressed or generally, how
Or
genuine.
Yeah,
that's right. Yes.
Because there's a difference, isn't there, between like a mental depression and then a physiological.
And I'm one of those people. I like to share the risk.
Yeah.
So if you have an issue with, for example, a very strong genetic issue, a BRCA gene or something like that, but that greatly increases your risk of breast cancer, I probably wouldn't start people on,
Can you check that?
Yes, you can. I now probably share the risk by sending you to a breast, a surgeon or oncologist or geneticist to get an idea of what the risk is first before we actually treat that person. So I think one of the very great things about having being in the center of the team is that I can then send you to the appropriate.
So you're like the project manager?
Project manager.
We do that we're like the project manager of finance. You're like the project manager of health.
Yes, that's right. Yes, but also one of the things too is that going back to the start when I'm trying to clear up all the definition, is that the average age of menopause is between 45 to 55, but there is a percentage of women that have what we call early menopause. So they go through menopause, between 40 to 45 or 40 to 44. So that's when we call that early menopause. Anyone who goes through menopause before the age of 40, that's premature menopause. The other name is premature ovarian insufficiency. And you can't just leave those women alone because you're basically letting their bones, rot.
Yes.
And not protect them.
So they actually need.
Well, they actually need it, and it would sort of like be, a crime not to, to ignore them. Yes. And also surgically, if somebody has really severe endometriosis, and if you have to need surgery to have a hysterectomy and remove your ovaries when you are fairly young, then you would need to put those women on some kind of hormones until they go through the natural age of menopause.
Or they could just stay on them.
Well, they can.
Yeah.
Yes.
Yeah.
No, they will make that choice.
That's right. Yes. Yeah. So just to sort of, I guess, to tidy this all up today, natural hormone treatments. What's your experience with those?
I think now, from a medical legal point of view, I think we would just try to put every woman on a bioidentical hormone wherever possible, rather than using. The Mirena you can't. Mirena is actually a synthetic progesterone, but the dosage is so low. It is a very small dose being released in your uterus. In very small amounts every day for the next 5 years. It's so slow. It's so low that there is actually no evidence that it is actually doing any harm at the moment. I mean, until there is any evidence, I have to let you know.
We'll get you back.
Yeah, but also, even before you go through menopause, how when you have a regular cycle, during your reproductive years, all of a sudden you start to have more and more irregular periods. That's actually the start of, an irregular period is the start of your menopause. It can start anywhere from 3 to 10 years before your menopause. So if the average age of menopause is 45 to 55, and if you start having your periods starting to be irregular because you're losing your eggs, you can start having symptoms as early as 35.
So an irregular period, would that also be a period that lasts one day instead of a week?
It is a gradual thing, because remember too, when you're born as a baby, we're born with, say, 2 million eggs in each of our ovaries. And as we grow up, by the time you start your first, by the time we hit puberty, we probably only have 500,000 eggs left, and then you keep losing them. So by the time you go through menopause, it's like, yes, we've got nothing.
That's done.
Yeah.
So there's hysterectomy all out, which was myself, and I'm glad I did get it.
And the great thing about hysterectomy is that all the clinical trials shows that because you only need to use estrogen, you don't need progesterone. So your risk of breast cancer is actually lower than normal women who don't take anything. I have excellent endo in Brisbane who recommended I do that. Yes. It actually makes everything so much more easier. This is not to tell everyone to go and ask for a hysterectomy, but no, and it did take me quite a long journey to get to that point. But it was the best thing for me that I ever did. Not that
weight matters, but I actually I put on a fair bit of weight quite quickly, and as soon as I had the hysterectomy, I lost it. And mine was obviously based on the endometriosis that I had sitting in there. Well, that's what my gynecologist
And with
told me.
respect to the endometriosis, if you did have really a lot of endometriosis, there may still be a little bit of endometriosis left behind. There is a small risk that because you're now taking estrogen, you can reactivate them, but I think that the dosage is so small, you probably don't feel
No,
it.
and I do go back.
Yeah.
So I see him every 2 years just for
But for some women who had endometriosis, even though they had a hysterectomy, there may be some cases where we may have to put them back onto some kind of progesterone.
Yes, okay. I kept my ovaries, but I got rid of my tubes, and that was because he said it will drop my chance of ovarian cancer by 50%. So I was happy I did all that. So that's one extreme. Then you could go to having estrogen with a marina, and not have to take progesterone, pessaries, or whatever, however you take progesterone.
Well, if you have a marina, then you just need to take, estrogen. Yeah.
And would you say that also cuts your risk of breast cancer a little by doing it that way?
There is no data
on that. And then
because your breast cancer risk for body identical estrogen, the breast cancer risk is also related to what kind of progesterone that you use.
Right.
So as long as you use a bioidentical, your micronized progesterone or
is
your
that Mirena?
no, that's not Mirena,
Okay.
but that's the premature.
Okay.
Yeah.
So that would be the third option, is to take the estrogen with the progesterone, and you take the progesterone on certain days of the cycle, don't you?
You take it. No, if you still have your periods and you're perimenopause, you probably will be taking it cyclically. That's just to try to match your cycle so that your bleeding is not all over the place. But once you've gone through menopause, we will just use a continuous.
Okay. And then obviously the last option would be to try natural for a while for someone who's still. I know we're not here talking about natural today, but.
Well, you don't have to take anything.
No.
There are women who probably can't take anything if they've had a history of breast cancer, for example. They probably.
And would even a natural be a little?
I think usually for a woman who've had breast cancer, unfortunately, people will probably just not put you onto any estrogen.
Yeah, and some of the natural medicines that you can take as like natural forms of estrogen, aren't they? Is that?
I don't know if they actually will do
Actually,
anything.
yeah,
There's not data for we only have data for what we prescribe. So anything that you buy over the counter or the complementary ones, we wouldn't know the consistency and the quality of the product.
So, and I guess creatine. I forgot to ask you about creatine.
But I'll just go back to the cardiovascular risk first. Because remember too, is that you were asking me about protection. We're talking about protection of a woman's future health, right? So you start losing your bones basically early, 1 to 2 years before you go through your last period. So you're already starting to lose your bones. Like when did you have your hysterectomy? So 2 years ago. So and that marks the actual time when you're supposed to go through. So we wouldn't know when you're going. But we know that in the first 5 years of going through menopause, you would have lost probably about 30% of your bone density. And it's very hard to put that bone density back.
Right. So for someone who's starting estrogen now, they're going to have stronger bones than someone who starts it at 60.
And so if you ask me to put somebody on estrogen at the age of 60, I can't really, just because we start estrogen, her bone density is not suddenly going to go back to what it was. That's actually not going to happen.
No.
But also from a cardiovascular point of view, because we also know that if I'm treating you for menopausal symptoms when you are early in your menopause journey, I'm also protecting your blood vessels, because estrogen has an effect on blood vessels to, make sure that they stay healthy and young. So if you don't take any estrogen, after about 10 years, your blood vessel will start to become more stiffer. You have an increased risk of atherosclerosis, which is like, they become stiffer, collecting cholesterol in the walls of the vessels. So if you don't, a woman who's not on HRT, their cardiovascular risk will increase probably 10 years after they go through menopause.
Does that also extend to the brain? I feel like vessels in the brain, dementia.
Possibly. But we're not giving people, but we're not prescribing for the pure purpose of, protection.
No,
Yeah,
no,
because
I
if you want to,
appreciate
if you want to prevent, if you don't want to have a heart attack, you've got other tablets like blood pressure tablets and cholesterol.
Yes, yeah, but there are still these underlying benefits, I think, that are becoming more and more.
Yes, they're just the hidden benefits. It's like, oh, well, we are relieving your symptoms, but yes, you might get some benefits from that.
My
as well.
hair was mine was a wonderful benefit. It's so soft.
Yeah. I don't know whether that's. I don't think there's a study for that, but
I'm a study. Thank you for today. Now, I'm hoping for all of our clients out there, email me any questions, anything. I can ask Janet anytime. You can make, if you're in Brisbane, go and see Janet. She's amazing.
I think the great thing is that because in my clinic, how I'm set up is because we spend extra time.
Yes, yeah. Janet does. She's an amazing. She also, we're not going to go into this today, but once you're with Janet, she looks at your overall, what makes you feel good. Like, do you how you look, how you feel. Janet's into the holistic, everything holistic about health. So, Janet looks amazing. I always go to Janet and say, can you make me look like you?
So she's just being too kind.
I know. So if there's anything that we haven't covered today, email me and I can get Janet back. Or email me for Janet's details and you can call Janet, go and see Janet, or find somebody locally who looks after you holistically. I don't love that word, but it's true. It's like the checks, everything from the start, and then take you through this journey. And just have somebody, to me, you're like what we do, just with money.
Yes, but if you ask me to look after, men's problems, I probably wouldn't know what to do.
No, I'm actually going to get a male doctor in, actually, because testosterone therapy is a thing. I think, like for men as well who are aging.
Yes, that's but you have to do that body too.
I won't get you. We won't talk. This is about women today. So,
yes.
Thank you so much for coming in today. Email me if you want to talk to Janet, or if you want her details, or anything like that, or any other questions. And stay tuned for lots more exciting interviews.